Hi, everyone, and thank you for joining today's virtual educational program with Cancer Support Community Los Angeles. I am Edlin Rodarte, and I am the program coordinator here at CSCLA. I'm excited to welcome you to this week's webinar titled, What's Important for Survivors of Brain Tumors to Know After Treatment? Before we begin, if this is your first time joining us, Cancer Support Community Los Angeles is a premier nonprofit organization providing social and emotional support to families facing cancer, including patients, caregivers, and their loved ones, all at no cost. Our programs include support groups, healthy lifestyle classes, social activities, and educational programs such as this one. If you'd like to learn more about our past webinars, please visit our website at www.cancersupportla.org. Before I introduce today's speaker, please note that we cannot see or hear you. Your video and microphone are automatically disabled for this webinar. We will not be monitoring the chat room, but you may enter your questions into the Q&A feature at any time. Questions will be answered at the end of the presentation, and you may not be able to get to all your questions today, but our presenter is invited to share their contact information at the end of the presentation. Without further ado, I'd like to welcome today's speaker. Karla Wilson has been the nurse practitioner in the Childhood, Adolescent, and Young Adult Cancer Survivorship Program at City of Hope in Duarte, California since 2006. Karla attended her basic nursing degree from Deaconess School of Nursing in St. Louis, Missouri. She obtained her master's in child health nursing at the University of Missouri and her postmaster's family nurse practitioner at the University of Southern California. Karla has been a pediatric nurse for more than 45 years and an advanced practice nurse for more than 35 years. Karla has authored chapters in pediatric textbooks, both authored and edited several pediatric oncology nursing textbook chapters, and co-developed the foundations of pediatric oncology CD-RAM educational modules. She has previously served as the president of Association of Pediatric Hematology Oncology Nurses and as vice president for the Oncology Nursing Certification Corporation. In addition, Karla was one of the founding members and developers of Pediatric Oncology Nursing Certification under the Certification Corporation of Pediatric Oncology Nurses, prior to it being incorporated under ONCC. Karla has also chaired the ONCC Pediatric Test Development Committee and ILNA committees. In addition, Karla was a member of the Livestrong AYA committee, and although she sees cancer survivors of all ages, the vast majority of her patients are in the AYA range. Welcome, Karla. Thank you so much for joining us today.
Thank you, Edlin.
Of course.
My pleasure to be here.
All righty, and the floor is all yours.
And
You're able to share your screen.
Share my screen. Doesn't seem to want to come up. Let me try that again. There, can you see it now?
We can. Are you able to put it in that different view when you go on top to display settings?
It is in slide view.
Right now it looks like presenter
Sure.
view for us, yeah.
Ah,
And then
okay.
there you go.
There we
Perfect.
go. All right. So as Edlin said, I'm a nurse practitioner in the Childhood and AYA Survivorship Program. And actually, prior to coming into this position, one of my areas of clinical practice was working with children who were diagnosed with brain tumors. So I'd like to give you a little bit of an overview today, and I will be happy to take any questions as they come up or at the end of the presentation. I do not have any disclosures. And just to start, I'd like to give a little bit of information about what is brain tumor survivorship. And if we think about cancer, we have to think about who gets cancer. And in the United States, there are about 1.8 million people diagnosed per year. Only 110,000 of these people are under the age of 40, and that makes up less than 2% of all cancer diagnoses. Then if we break that down and look at who has a primary brain tumor, and when we talk about a primary brain tumor or primary central nervous system tumor, we're talking about brain and spinal cord. And the expected incidence in this year is that there will be about 5,200 children less than the age of 20 and around 25,000 adults with, that's classified as being greater than 20 years of age. Of that, 14,000 will be men and 11,000 will be women. And approximately 15% of all brain tumors that occur are in people between the ages of 15 and 39 years of age, and that's described as the Adolescent Young Adult, or AYA population. During this talk, I'm only going to be talking about issues related to primary brain tumors. I'm not going to be talking about brain tumors that occur as a result of metastasis. For example, you can have lung cancer or breast cancer. That's your primary cancer, and it can metastasize to the brain. And that's a totally different type of management of those types of diseases compared to people who have a tumor that originates in the brain or spinal cord. So if we look at some of the survivor statistics, the overall survivor rate between 5 and 10 years after treatment is greater than 30%, and that's lumping everybody, all ages, and all types of brain tumors into one category. If we look at that 5-year survival rate by age, children that are 15 or less in age when they're diagnosed, the survivor rate is about 75%. For the AYAs, it's just slightly lower. But when you get to people who are diagnosed after the age of 40, the survivor rate drops drastically, and that's down to about 21%. And part of the reason for this has to do with the types of tumors that occur. And in adults over the age of 40, one of the most common types of tumors is a GBM, or glioblastoma multiforme, which is unfortunately a type of brain tumor that does not respond long-term to treatment. So what we really want to care about is what happens to the individual and what can we do to try to have the best quality of life. So I'll go on to talk about what are some of the common late effect risk from having a tumor of the brain. So first off, it's important to know what late effects are. Late effects are actually healthcare issues that arise or persist after all treatment has been completed. A risk for a late effect is based on a variety of things. Age at diagnosis is one of the key components, as well as location of tumor. What was the treatment? Did it involve surgery, which is the classical treatment for almost all types of brain tumors? Did it involve chemotherapy? There are many types of brain tumors that do not respond to chemotherapy, or chemotherapy may not be necessary. Is radiation used? And when radiation was used, what was the cumulative dose? What was the type of radiation given? And what was the location of the radiation? All of those are really important considerations when you think about potential late effects of treatment. And why do we consider late effects important? We know that a late effect can not only influence the quality of life a person has after treatment, can also influence their quantity of life. We know that having a brain tumor and having treatment for a brain tumor puts patients and people at risk for cognitive function impairments, as well as a variety of physical health conditions. We also feel that if there is early recognition with intervention, that might help to minimize some of these late effects so that they are more manageable, as well as not decreasing the person's quality of life. So what are those health risks that are associated with treatment? Well, we know that many long-term survivors have at least one late effect, and many have multiple late effects. And those late effects can be anywhere from mild to severe. We also know, and I'm sure people that are either patients or our caregivers are very aware, that some of the conditions that a person has following treatment are really not well recognized in the general medical community. Primary care providers may not have the knowledge that's needed to really help patients have the best quality of life and get the appropriate screening that they need to have based on their previous treatment. Again, we think early intervention can improve treatment and actually improve the potential outcome. And when we think about late effects, we really look at them as being based on 4 major areas. Growth and development, that's particularly important for young children who are getting their treatment before they've completed their skeletal and linear growth. There's issues related to emotional and social maturation. There can be issues related to sexual development as going through puberty. And there can also be significant issues related to intellectual function. We know too that there's vital organ function issues. Brain tumors can affect vision, and treatment can actually also affect vision too, but the tumor itself is what puts you at greatest risk for visual issues. Hearing can be affected based on the location of the tumor, but then it can also be affected by the radiation as well as a type of chemotherapy given. One of the chemotherapies that has been found to be very helpful in treatment of brain tumors is a category of chemotherapy agents called platinum. And unfortunately, one of the side effects of platinum drugs is that they can damage the eighth cranial nerve that controls hearing. So monitoring of hearing becomes a very important component for many people with brain tumors. There can be cardiac and pulmonary effects from both the radiation and certain chemotherapy agents. Endocrine or hormonal effects are a huge area of problems that can occur in someone who's been treated for a brain tumor. There can also be issues related to the kidneys and the GI tract. There might be issues related to fertility and reproduction, concerns about the health of the offspring. We do know in general that cancer survivors who have children, their children are not at any greater risk of developing cancer than the children of people in the general population. There are some specific caveats to that, but in general, that's a true statement. And we also know that second tumors can occur primarily from the radiation therapy. These tumors can be benign, which means underneath the microscope, they aren't cancer. But a benign tumor in the brain can cause as much damage sometimes as a malignant tumor of the brain. And a malignant tumor is one that underneath the microscope, it is definitely a form of cancer. But all of these 4 components have an impact on what's the health-related quality of life for the individual. So during this talk, I want to highlight 3 of the main areas that I feel that people with brain tumors who have had treatment might undergo. And one of the most common areas is related to endocrine health, which is related to your hormones. So the endocrine system makes up glands that produce or secrete hormones and other chemical substances, and they regulate activities of other cells and organs. They might control mood, they might control metabolism, they certainly can control how an organ works. So for example, the pituitary gland in the brain, if it's radiated, it might cause a problem with the thyroid gland in the neck getting the hormones that it needs to produce thyroid hormone. Endocrine hormones are also extremely important for growth and development, and this is especially true in children who have not completed their full growth and development when they receive treatment. Endocrine hormones are also very important for reproduction and sexual function. So the pituitary gland in the brain is called the master gland. So it's basically the boss. It tells all other glands in the body what to do and how much hormone to release. So there are hormones, though, that are made directly in the pituitary gland. The first one is something called growth hormone, and growth hormone is extremely important for linear growth, but it's also important for some general health concerns, such as control of your cholesterol. And I'll go into a little more detail in a few minutes. The thyroid stimulating hormone comes from the pituitary gland, goes to the thyroid gland, and tells the thyroid gland it needs to produce thyroid hormone. The antidiuretic hormone, or ADH, is really important in fluid electrolyte balance. The adrenocorticotropic, our stress hormone, known as ACTH, is very important for being able to respond to stress and to an illness. When we think about gonatrophins, or puberty hormones, we think of something called the luteinizing hormone, or LH, and the FSH, which is the follicle stimulating hormone. And then we have other hormones called prolactin and oxytocin. So we know that injury to the pituitary gland by either surgery or radiation can cause hypopituitarism. And what that means is you have inadequate production of two or more of the hormones secreted by the pituitary gland. And if you have pan-hypopituitarism, you're lacking a production of almost all hormones produced by the pituitary gland. And when that happens, you have to have replacement of those hormones by medications. So this slide just gives you some examples of some of the things that can occur if you have a hormone deficit. So ACTH, you have something called adrenal insufficiency, and a person might have problems with fatigue, dizziness, a decreased blood pressure, or hypotension, and they're unable to respond to stress. So treatment is you have to take a cortisol hormone. And when you're on this hormone, and that's something you will be on usually for life, you often have to have an increased dose when you become ill. Say you get the flu, you might need to have extra medication in order for your body to cope with the illness. The TSH, as I mentioned, is the thyroid stimulating hormone. And if it's not telling the thyroid gland what to do, then the thyroid doesn't produce the thyroid hormone, and you have hypothyroidism. You can have depression, lethargy, thinning of hair, weight gain, and a hormone supplement called levothyroxine or Synthyroid, and there's a variety of brand names, is the oral medication that you then take to replace the thyroid hormone that is not being produced by your body. For gonadotropin hormones, that causes hypogonadism. And what that means, it puts you at risk for infertility. You will have a decreased sex drive, and you might develop osteoporosis. That's premature thinning of the bones. And we typically kind of think of osteoporosis as something that happens to women after menopause, but it can happen to anybody at any age if they don't have appropriate hormones. Treatment for that is hormone replacement therapy, which for males is testosterone, and for females is a combination of estrogen and progesterone. And then another hormone called the antidiuretic hormone. If you do not have that hormone in sufficient supply, you can develop something called diabetes insipidus, or DI. That causes excessive thirst and urination, and it can cause your blood level of your salt or your sodium to drop. Parents will talk about their kids, their 3-year-old, they keep drinking water out of the fountain and they can't seem to get enough to drink. And they're urinating all the time. And so that's a clue that you need to check what their ADH is, and they may need treatment for that. That's a form of a hormone called DDAVP or desmopressin, and that can be given either orally or can be given by a nasal spray. And parents of children who have a diabetes insipidus get very good about learning how to adjust the dose of the DDAVP based on their child's symptoms. So for thyroid issues, hypothyroidism is the most common thyroid problem that occurs. And as I mentioned, patients may have lethargy, but they also may have depression. They often have dry skin and hair. They're intolerant to cold. They may get a puffy face and gain weight. Their energy is low. They have muscle weakness. And the treatment for that is thyroid replacement medicine. And it's so important that that be taken every day, that you don't miss doses. And you're basically just replacing what your body's not making, and then you can have totally normal function for that. Typically, once you get on the right dose of the thyroid replacement medicine, other than in growing children, you often will be on that same dose for life, because it becomes pretty stable and keeps your thyroid levels at a steady state. Hyperthyroidism can also occur, and that's when you produce way too much thyroid medicine. It's much less common than hypothyroidism, and typically patients are very sensitive to heat. They might have a swollen thyroid, or their neck might be very thick or swollen looking. They often will be anxious, get agitated very easily, and have pretty significant mood swings. They might have a very rapid heart rate. Their heart rate might be very uneven or irregular, and they often might have palpitations. So treatment for this is anti-thyroid medication. So the opposite of hypothyroidism. So you have to give something that suppresses the production of the thyroid hormone. It may also be done by radioactive iodine, and occasionally the thyroid gland actually has to be surgically removed. The other issue that can occur with the thyroid gland is thyroid cancer. It's more common in children when they've been treated with radiation. It usually occurs within 5 to 10 years after the radiation. You may sometimes have palpable nodules on the thyroid gland where if you feel it, you can feel lumps. If the thyroid gland itself might be quite enlarged. A biopsy is done, and then if it shows malignancy, treatment generally is surgical removal of the thyroid gland, plus or minus getting radioactive iodine in order to wipe out any residual cells. The good news is this is extremely treatable and extremely curable. Growth hormone deficiency is extremely important. And we know that the damage to it is from radiation. The higher the radiation dose, the greater risk of having growth hormone deficiency. If children who are prior to their puberty have low dose radiation, they actually might initially develop premature puberty, and then they go into growth hormone failure if you don't stop that premature puberty. High dose radiation, though, can cause outright growth hormone failure and delay puberty from starting. And in females, it can cause premature ovarian failure if the female has already been through puberty when they receive the radiation. The risk and severity and when growth hormone deficiency develops can be related, again, to the dose of radiation, to that hypothalamus pituitary axis in the brain. How old was the child or the patient when they were treated? The greatest risk of growth hormone deficiency is when children are less than 10 years of age at the time of their radiation. Although growth hormone deficiency can occur in anybody who has cranial radiation, regardless of their age. In adults, growth hormone is not related to height or achieving height that people think about growth hormone is needed in children. It's important for brain function. It's important for your muscle mass development. It's important for bone health. It's important for cholesterol health. And growth hormone deficiency can cause you to collect fat, especially around the trunk. So people with growth hormone deficiency may have a very thick middle and a large waist. So that obesity of the trunk, but you can also have greater heat and cold intolerance. You might have decreased sexual function or even decreased sexual interest. Again, anxiety and depression can occur. There are feelings of being socially isolated. You do start having less muscle mass, so you have decreased strength and stamina, and you have increased fatigue. You can have reduced bone density, which increases your risk of fractures as you age. And there are patients who need to be on growth hormone replacement for their entire life. So again, as I mentioned, it is damage to that pituitary gland or the hypothalamus, which is adjacent to the pituitary gland. In order to diagnose growth hormone deficiency, it might involve an MRI of the brain to see what the area of the brain looks like. And then there is a test done called a growth hormone stimulation test that's done over a couple of hours where you have an injection of a hormone and then you have serial blood tests drawn. Treatment is growth hormone injections. There are intermittent blood tests to check what the growth hormone level is. And there's monitoring of the bone density, which is called a DEXA scan to see, are you developing osteopenia or osteoporosis, that premature thinning of the bones? And what are your cholesterol or your lipid levels? And for any patient who has had a brain tumor, I think at minimum, they need to have a consult with an endocrinologist who's a hormone specialist. And frequently, post-treatment, the endocrinologist might even be one of the most key members of your entire team to make sure that your hormonal health is as good as possible. So next, I'd like to talk about neurological function and cognitive issues, because that's another huge area that impacts survivors of brain tumors. So some of the things that we see are balance issues. That's called ataxia. Often patients with balance issues will have a wide-based gait, so their feet are further apart than normal in order to walk. And that's because if your feet are further apart, you can control your balance better. And people with ataxia can be very high risk for a fall. Other issues that can occur are seizures. You may not have had seizures at the time that you were diagnosed, but you can develop seizures years after your treatment, and that can be from injury from radiation to the area of your brain that has what we call the seizure foci. You might have hydrocephalus, which is where the ventricles, which are fluid-filled chambers within the brain, the pathway gets blocked, and those ventricles get enlarged, and that puts pressure on other areas of the brain, and people might need a shunt in order to get that fluid from backing up in the brain and get eliminated. And that's usually done with something called a ventricular peritoneal shunt. So it actually, from the shunt up in the brain, there's a little tube that goes down into your abdominal cavity, and that fluid can be easily absorbed. There are times when somebody has hydrocephalus that the neurosurgeon can actually kind of open up the pathway without having to have a shunt. So that's very dependent upon the individual situation as to what method might be used for treatment. People may also develop things like neuropathies or paralysis, muscle weaknesses, loss of mobility. Paralysis can often is on one side of the body, and you have weakness or actually complete inability to move that side. There are a lot of psychological disorders that can occur, such as anxiety, depression, suicidal ideation, often low self-esteem. And particularly for kids diagnosed when they're young, there can be social isolation and lack of peer interactions. There can be cerebral vascular disease, and that means there can be issues with the blood vessels within your brain because of the damage that was done from the radiation. And then you can also develop second brain tumors, as I mentioned before, which can be either malignant or benign. And then neurocognitive late effects, what are they? Well, we think of them in a couple of ways. Functional deficits, such as your executive function. How do you plan? How you do organization? There can be issues with sustained attention so that people are easily distracted, which can be a huge problem for kids in school. There can be memory issues, primarily short-term. There can be issues with visual sequencing and temporal. I'm also kind of a visual spatial recognition. Significant issues often occur with processing speed, meaning that it takes longer to get from point A to point B in your brain than what it should. There can be issues with fine motor dexterity, especially if one side of the body is weaker than the other. That's the side that's going to have the biggest problem. Visual motor integration, what you see and how you move, and language and academic fluency. Learning deficits are often related to math. There can be issues with reading, especially related to comprehension. With higher doses of radiation, there can actually be a diminished IQ, and there can be behavioral changes. And children with mild deficits may actually fall through the cracks, as deficits aren't obvious. They might be labeled as being lazy or not paying attention. And part of that's because of short-term memory issues, that easy distractibility, but also that processing speed I mentioned. Maybe they have 30 minutes to take a test in school. Well, the 30 minutes is up and they're only halfway through. And so it's, well, if you would have studied harder, or if you would have done this, or if you would have paid attention. They often will feel overwhelmed getting homework assignments done because they can't get through the volume that they've been assigned in a time period that is relatively reasonable. So what do we do? And what does this mean? So we have to think about, how did the child originally present and how did they get their treatment? Did they have ataxia and seizures and hydrocephalus or visual changes when they were diagnosed? Did their treatment directly impact their learning potential? In children, the vast majority of children, 2/3 of them, their tumor is in something called the posterior fossa, which is the back of the brain, or the cerebellum. And that area of the brain is so important for coordination. And it's not just coordination of their physical movements, but some coordination of their brain processes. If they had posterior fossa syndrome after surgery, they might have mutism, they might have difficulty swallowing, they might have a hyperirritability. And unfortunately, posterior fossa syndrome occurs more commonly now because as surgery has gotten better and better at removing brain tumors, there's more likely to be irritation or injury to the base of one of the fourth ventricle, and then children will develop this problem within a few days after surgery. It can last for days, weeks to months. And children who have posterior fossa syndrome tend to often have an increased incidence of that cognitive functions, processing, executive function later on. If children had platinum therapy or they had high-dose cranial radiation that affected their 8th cranial nerve, that can cause hearing loss. And when you have hearing loss, sometimes you're missing bits and pieces. So you might be missing key blocks in that building process of education and learning. And low-grade hearing loss often isn't picked up right away. And so we screen children for hearing on an annual basis until they're at least 10 years of age. And then they need to be screened every 5 years. Or if they report, or their teacher reports, or their parents report that they don't seem to be hearing as well, then you do that hearing screening more frequently. And one of the things that we also think about, after you've completed your surgery and treatment, did those presenting symptoms improve or even go away? So what causes issues with cognitive effects? Number one is location of the tumor. Location of the tumor determines whether or not it's surgically resectable. Location of the tumor determines what potential permanent damage is done to that area of the brain from pressure of the tumor. Location of the tumor also determines what type of radiation and where the radiation is given, although the histology or the type of tumor also determines that radiation field. Do they need a higher dose radiation? Are they getting radiation to their temporal lobe? Because their temporal lobe is an area that if that area is irritated, seizures are more likely to occur. Are they getting their entire brain radiated? Are they only getting the exact area where the tumor was radiated? That has different implications for a potential risk of late effects. And who has the greatest risk? Females, unfortunately, do have a greater risk than males of having cognitive issues. Children less than 3 years of age have the overall greatest risk, but all children can have a risk. And if a child has a pre-existing history of learning or attention problems, those things are probably only going to worsen after treatment for a brain tumor. We also know that the greater the time that has elapsed from the therapy, that there's a greater risk or worsening of the neurocognitive deficits, and that's primarily from cranial radiation. Although some young children who are treated with chemotherapy only, the hope was that that would decrease any incidence of cognitive effects, but unfortunately we are also seeing cognitive effects in those children as well, although not as severe as what you see from radiation. So how do we screen for neurocognitive deficits? Well, it's really important to ask about school or work performance for someone who is older. And I have a lot of patients, so when I ask them, well, how's school going? How's work going? They'll say good. So I ask them, what does good mean? Because good might mean something different to them than it would be to me or to someone else. And what are their sleep and fatigue patterns? We know that if a person's fatigued, they don't function as well as when they are more rested. We recommend neuropsych evaluation or testing, and that neuropsych testing evaluates your memory, your verbal fluency, your processing speed, your visual motor integration, your computer-based attention, your executive function and planning, and your comprehension of verbal instructions. If you're told something verbally, do you understand and can you do what you're being instructed to do? And so simply said, neuropsych testing assesses how someone learns and what are their strengths and what are their weaknesses. And that can also help then provide strategies to use your strengths to help compensate for some of your weaknesses. So what comes next? For children, I highly recommend most kids who have had a brain tumor to be referred to the regional center for an evaluation. And they should have resources for schools, such as a 504 education plan or an IEP, which is an individualized education plan. It's also important that college students be evaluated because many kids will qualify for special accommodations. And it doesn't matter if they're in grade school, elementary school, high school, or college. They can be provided with longer test taking time. They may be able to get a decreased assignment workload, and they may also be provided a testing environment that reduces distractions. It's also important to refer to community resources, such as vocational rehab, or programs for adults with disabilities. And there's something called cognitive rehab therapy that can be helpful in improving a person's ability to utilize, again, techniques to help improve their cognitive function. And just to give a little bit background information about California regional centers, a regional center will help plan, assess, coordinate, and monitor services and support for persons with a developmental disability. Does not have to be from a brain tumor, it can be for any reason. And so the first step is identifying if a person has a disability that makes them eligible for services. And something that is key, they must be enrolled prior to the age of 18. if you have, say, if somebody who's diagnosed with a brain tumor at 15 or 16, they seem to be doing okay. And then now they're 19 and they have obvious deficits. You've missed that window of opportunity to get them services through the regional center. So I frequently recommend that all patients get an evaluation to see if they would qualify for services. And if they do, then they can maintain those services as they age. And the planning team with the regional center can be very helpful to coordinate services. And they can include things like outreach, counseling, resource development, what training and educational opportunities are there, assistance in accessing community resources. And the other thing that's really important is when you have young children, there are specific programs for early intervention for infants and toddlers that can make a big difference in how they grow and develop. And there can also be some help with planning of placement and monitoring of 24-hour out of home care services. And then with cognitive rehab therapy, it's really a group of different types of therapies that can be provided by an individual or a team, and they might be people such as speech and language therapists, occupational therapists, physical therapists, etc. The goal is to enhance functioning and independence in patients with cognitive impairments. It's to help with learning of coping skills, techniques to help improve memory and increase attention span. And there's some thought of retraining the brain by practicing skills that have been impaired. And the ultimate goal is to overall improve quality of life. Unfortunately, there can be some insurance challenges to get them to pay for CRT. It might require that you get letters from professionals. It might be a lot of work to provide the rationale why a person should be given it. The Institute of Medicine several years ago came out supporting ongoing clinical application of cognitive rehab therapy intervention for any individual who has cognitive and behavioral deficits due to a traumatic brain injury. Unfortunately, children with brain tumors, who I personally think that's one of a significant traumatic brain injury, aren't often classified as having a traumatic brain injury, but there can be workarounds to try to get these services. And I have had fairly good success with a lot of patients being able to get cognitive rehab therapy. It's just sometimes you just have to jump through the hoops to get the services. So some of the important key points that I think are important for anybody with a brain tumor are a caregiver of a person with a brain tumor. It's important to ask and find out about school and job struggles. It's important to get a neuropsych evaluation early on and get them repeated at intervals that are going to be determined by the individual person. I personally think any patient with a brain tumor should get neuropsych evaluation. Earlier interventions can prevent or minimize some of the cognitive issues. And it may keep a kid from dropping out of school, particularly one of those kids who are in that gray zone. It's not real obvious and they get labeled and they get discouraged. College students might need to be encouraged to take a lighter load in order to be more successful. And it's really important to try to empower people to discuss their cognitive issues with an employer. A few years ago, I had a patient who had developed pretty significant memory and that speed of processing issue. He was originally diagnosed with a non-brain tumor as a kid, and then he had a brain tumor as a young adult. And after he'd already graduated from college, and he was actually a teacher, he wasn't able to go back to teaching. And at that time, it was before the Affordable Care Act, and insurance was much more difficult to get because of pre-existing illnesses. And Starbucks provided health insurance for employees, even if they worked part-time. He got a job at Starbucks, got insurance through them, and then he called me saying he felt like a failure. he was struggling. He couldn't do the work. He couldn't remember the recipes. He couldn't get work fast enough to get the orders out. So he gave me permission to talk to his manager, who fortunately was very receptive. And so he got switched to a shift time that was less busy, instead of being at the overwhelming busy time in the early morning and right after work, that kind of thing. And then that allowed him to become successful. And he did quite well and actually went up to become a manager and all. So it's important to have these types of discussions. So I encourage healthcare professionals to make sure that you support a patient. As a parent or a caregiver, do what you can to help support them. It might involve contacting school or employers. And of course, anything done has to be with the permission of the patient. And there are times that certain medications, psychotropic medicines known as stimulants, may actually improve some of the cognitive function and can be appropriate for some patients. So it's always important to seek and find out what's out there, what can be done that might provide help for you. So the next few slides, I'm not going to go over them verbatim by any stretch of the means, but I wanted to provide some resources, things that can be helpful for school, vocational housing, social programs, because one of the huge issues for people with brain tumors is that social isolation. And sometimes it's for the caregiver that needs that support. So for example, the Immerman Angels will connect you to a peer, whether it be another caregiver peer who's in a situation like the caregiver, or is it a patient? One of my patients who was diagnosed as a 5-year-old, and now she's in her early 20s, she connected with a peer through Immerman Angels a couple of years ago, and she has weekly calls with her peer who happens to live in New York. So there are things that you can do that can be helpful. I2Y, also known as Stupid Cancer, is an adolescent young adult cancer support group that has really been helpful in helping end isolation and helping people develop community. There are some camps that are very important and helpful. And here in Southern California, we're really fortunate to have the Ronald McDonald House and Camp that can provide a lot of support and resources for patients and families. This is an example of some of the programs that people can get scholarships to help with college or vocational education. And there are other resources out there, so I just wanted to provide an example of some that are available. There are advocacy groups, such as the American Brain Tumor Foundation, the Pediatric Brain Tumor Groups, the Cure the Kids, Cure Search, etc. Here at City of Hope, we have our Childhood and AYA Survivorship program. We're a clinical research program where we assess survivors of childhood and AYA cancers to see what their actual potential late effects are, and give them information. And this is a program where we see patients on an annual basis. We provide a treatment summary that you can share with your other healthcare providers. We give you information about what screenings are valuable to you and what types of things can be done. Anyone who was diagnosed prior to the age of 40 is potentially eligible to come to our program. We also have something called the AYA Toolkit here. This is a relatively new resource. It provides information for both the AYA patient and their family. They have a Facebook page where you can get updates about other programs. They do also have a peer connection program. And they have a couple of times a year, they do an 8-week class for empowering young adults about coping with the life that you've been handed. So those are all resources that people might find of value. And so are there any questions for me?
Hi, Karla. Thank you so much for that great presentation. And yes, we do have some questions that have come in, so we can go ahead and get to that portion of the presentation. Staying on track with the City of Hope survivorship program, somebody asked, do kids need to come out to City of Hope or can they do Zoom?
The initial appointment is in person. We do some Zoom follow-up. I have to say that's been one of the side benefits of COVID. It caused us to develop a platform for telehealth, but the initial evaluation would be important to be in person.
Okay, perfect. And then somebody asked, what recommendations or advice do you have for the best ways caregivers can support their loved ones?
That's a really tough question, and there are probably dozens of different potential answers. And unfortunately, it's somewhat dependent upon the individual and the precise situation. But I think one of the best ways to start is get connected to some of the peer groups and get ideas from other people. And also to talk with the healthcare provider. What's the particular problem? Is it global, or is it one specific area? What resources are available for that identified problem? It's so important for hormone assessment, because if somebody's hormones are off, that can influence things like depression and motivation and whatever. So making sure that the physical health has been well evaluated, and if interventions are needed for the physical health, that those interventions are taken to see what you can do to improve health. I think getting people connected to resources, getting people connected to other people, all of those things can help both the caregiver as well as the patient. And over the last 10 to 15 years, there's been a huge look at something called caregiver burden. It's, as all the caregivers out there know, it can be very difficult to always be there and always be on to help your family member, whether it be your child, your spouse, your partner, whatever. But getting connected to resources and getting connected to other people is probably going to be an extremely important first step.
Yes, that's great. Thank you so much. And in addition to that, somebody did ask, because you did have such wonderful resources towards the end of your presentation, if your presentation would be made available like in a PDF to share.
Would you provide that? How would that
Yeah,
be?
I could do that since
Yeah.
Okay, perfect.
That would be
So
fine.
we will go ahead and share that. If anybody is interested, I'll just go ahead. You guys can email info@cancersupportla.org, and that will be in the chat. Another question that came through was, what about cannabis or CBD for seizure control for kids?
I'm not an expert. I know that there has been some efficacy. I know that Colorado was kind of the leader in that, and there are people who moved to Colorado to go to the University Colorado Children's Hospital because they did that. I don't have enough knowledge or efficacy to really comment heavily on that, but I know that it has been helpful for some people.
Okay. That's great. Let's see. Another question was, the survivor journey seems overwhelming. What late effects of treatment are the most important to consider?
It's totally based on the specific treatment. Okay. We use the Children's Oncology Group late effect long-term follow-up guidelines. And based on your specific treatment, it will identify what your most likely risks are going to be. So you can have two people who have a quote brain tumor, but they had very different therapies. So the risks are going to be based on that very individualized treatment.
Okay. Somebody asked, is there a way to avoid like late effects of treatment or lessen the effects of a certain treatment or treatments out there?
The answer to that is possibly for some things, but in the whole big picture, not so much. Although one of the purposes of our late effects program is to learn knowledge, to see how we can lessen treatment and still have a good cure rate. I think the most important thing is making sure that you stay connected. I think any patient who is a cancer survivor, if they have the opportunity to attend a late effects program for that evaluation and screening, that can be extremely helpful. And just like healthcare in general, when we look at oncology, we now have people who specialize only in working with patients with leukemia or lymphoma, our bone tumors, our brain tumors, but we now have this whole subspecialty of people who are experts in late effect identification and management. So having that connection can really inform you of your potential risk factors and what you can do. You can't go back and change the treatment you had, but you can look at what can I do to have the best quality of life moving forward. And part of that is you have to be your own advocate, and you have to take care of yourself, and you should follow the recommendations. For example, if you have treatment that puts you at greater risk for developing, say, high cholesterol, watching your diet, watching your weight, watching your exercise can all help control that issue better. The more you stay engaged with other people, the more that you challenge your brain, might keep you more focused. So there are proactive things you can do. There are things that are totally out of your control, that no matter what you do, things don't go the way you want them to do. But I think getting healthcare is so crucial. It's also important not just to be involved with a long-term follow-up program, but to have a primary care provider and educating your primary care provider about what are your risk factors, what is needed, and finding a primary care provider that will listen to you and will answer your questions. So all of those things can help you have a better quality of health and health care.
Yeah, I think that's very well said. Thank you so much for that. So it looks like we're coming up to the top of the hour, and we do have one last question. Somebody asked, how long does it take for a person to physically heal from treatment?
Again, that's somewhat individualized, and it depends on what you're talking about. If you're talking about having brain tumor surgery, depends on the area of the brain. If the incision's in the top part of your brain, that healing process is pretty quick. If it's in that posterior fossa, which is right above the neck, that healing process takes longer. And so there's not a one and done answer. It's very, again, individualized for the specific person.
Okay, that's understandable. Well, thank you again, Karla, so much for your time, for all your knowledge that you spread to our community today. We're grateful that this is being recorded to everybody who is here and wasn't able to attend. This will be up in our video library, hopefully within the next week. You could always visit our website at www.cancersupportla.org. And I'm also dropping the website in the chat right now. But thank you everyone for attending, and Karla, so much for your time again. And we appreciate you and appreciate everyone for joining us today. We hope you have a great rest of your afternoon.
Thank you so much.
Take care. Bye.